claims against the affirmative would keeps inconvenienced relatives from suffering patients that do not want to live the rest of their time from persuading him or her to voluntarily ask for death. Also, doctors, nurses, and other hospital staff can only do so much without going out of turn, and assisted suicide will not solve these problems, but create a lot more. Patients that receive lethal medication are not provided additional care when they go home to take the medication. On the website for Physicians for Compassionate Care, on their top 10 FAQs, one says, once a patient has the needs to take their own life, there can be decreased incentive for the care of their patient's symptoms and needs. The case of Michael Freeland is an example. Michael had been given a legal prescription, and when his doctors were planning for his discharge to his home from the hospital, one physician wrote that while he probably needed attendant care at home, providing additional care may be a moot point because he had life-ending medication. His assisted suicide doctor did nothing to care for his pain and palliative care needs. His seriously ill patient was receiving poor advice and medical care because he had legal drugs. The American Medical Association, on their policy E2.21 on euthanasia, states that instead of engaging in euthanasia, physicians must aggressively respond to the needs of patients at the end of life. Patients should not be abandoned once it's determined their cure is impossible. Patients near the end of life must continue to receive emotional support, comfort care, adequate pain control, respect for patient autonomy, and good communication. In Wesley Smith's J.D. writes in his 1977 book, Forced Exit, studies show that hospice-style club care is virtually unknown in the Netherlands, where euthanasia is legal. There are very few hospice facilities, very little in the way of organized hospice activity, and few specialists in palliative care, although some efforts are now underway to try and jumpstart the hospice movement in that country. The widespread availability of euthanasia in the Netherlands may be another reason for the sudden growth in the Dutch hospice movement. As one Dutch doctor is reported to have said, "Why should I worry about palliation when I have euthanasia?" Euthanasia should not be legalized because of the words of Hubert Hendon, MD, writes in his article, The Slippery Slope, the Dutch example. Over the past 2 decades, Dutch law and Dutch medicine have evolved from accepting assisted suicide to accepting euthanasia, and from euthanasia to terminally ill patients to euthanasia for chronically ill individuals, and then evolved from euthanasia physical illness to euthanasia for psychological distress. Finally, evolved from voluntary euthanasia to the practice of conditional acceptance of non-voluntary and involuntary euthanasia. Once the Dutch prohibited assisted suicide, it was not possible medically, legally, or morally to deny more active medical help, such as euthanasia, to individuals who cannot effect their own deaths.